very warm welcome to all of you. Thank you so much for your cooperation and patience, really. Sometimes these things happen. I would like to introduce Dr. Reema Bansal once again, who is our esteemed faculty for today, who will be speaking on imaging in posterior uveitis. Dr. Reema Bansal is an additional professor in PGI Chandigarh. She has 127 publications in peer-reviewed journals with 25 chapter books and 10 awards to her credit. She has delivered about 120 guest lectures in national and international conferences. She has completed a research fellowship in the United States of America. She is an elected member of the International Uveitis Society Group and National Academy of Medical Sciences, and she is the reviewing editor for the Ocular Immunology, Inflammations, and assistant editor in the Indian Journal of Ophthalmology. A very warm welcome to you, Dr. Reema Bansal. Thank you so much for giving us the time and effort to teach our postgraduates in this program today. We'd like to request you to please begin your presentation on imaging in posterior uveitis.
Thank you, Dr. Sinha, for such kind words and kind introduction. And hello to all the students who've been waiting. Apologize for these technical issues. So, imaging in posterior uveitis, can we move on the slides, please? So, these are the basic modalities when we talk of posterior uveitis: fundus fluorescein angiography, fundus autofluorescence, ICG angiography, OCT and OCT angiography, ultrasound, and sometimes ultrasound biomicroscopy. So these are the ancillary investigations which form the backbone of uveitis workup, both for anterior and posterior segment diseases. They help in not only making the diagnosis by ruling out certain differential diagnoses, but they also help in monitoring inflammation during the follow-up. So by this presentation, I'm going to give you an overview describing the role of commonly used investigations for posterior uveitis. So the first and foremost, which may be ignored by many of you, like I said, I started with fundus fluorescein angiography, but before that, most important is fundus photography. And we really don't pay much attention to it. And as a student, you must, and I'll tell you why. It serves as a very useful tool for monitoring the progression or regression, that is improvement of the inflammation of the retina and choroid. Fundus photography is routinely useful in all cases of posterior uveitis to document the lesions at the baseline, and then use these photographic images for comparison to document the healing or progression of the lesions. Now, next slide, when we see a case like this, so this is the initial presentation. And when we treat this patient, we have the follow-up like this, which shows that the lesion has remarkably reduced, and this is the final follow-up. So this is very good for documenting the improvement. Whereas, on the other hand, if you have a lesion like this, where we have documented by fundus photography, and the patient goes on the next visit like this, you know that he's or she is worsening, and you have a very good documentation to show that, yes, the patient has worsened. Or when we are monitoring the treatment response in a patient of serpiginous lycoroiditis, where initially, as you can see on the left, this is how the patient presents with. And when we go on serial follow-ups, we have a very good scarring in the end. Or to monitor the paradoxical worsening. Yes, next please. Paradoxical worsening, where you can see that the lesions were not all that bad, but on the next follow-up, they became worse and finally started responding to treatment. Now, when you have lesions like this, it's not only the fundus photography which is important, you have something more to fundus photography. And now we come to fundus autofluorescence. So fundus autofluorescence is decided, the pattern is decided by the pattern of lipofuscin distribution in the retina. It is the stimulated emission of light from the lipofuscin which is present in the RPE cells, from which the autofluorescence images of the fundus arise. In normal visual cycle, there is a constant phagocytosis of the photoreceptor outer segment discs. The lipofuscin granules accumulate as a result of this in the lysosomal compartments of the RPE cells as a byproduct, and diseases which have a pronounced effect on the morphology and function of the RPE exhibit changes on fundus autofluorescence. Now we can have a hyperautofluorescence, which is an increased autofluorescence, or a hypoautofluorescence, which is a decreased autofluorescence. It is a metabolic activity within the RPE photoreceptor complex, which is decided by these hyper or hypoautofluorescence. So basically, hyper when means when there is increased shedding of photoreceptor outer segments. That means there is an active metabolic disease. Hypoautofluorescence means there is death or atrophy of the photoreceptor cells, disruption of the visual cycle, and atrophy of the RPE cells, indicating an irreversible damage. So when you talk of autofluorescence and fluorescein angiography, you need to know the basic difference between the two. Fluorescein angiography tells you about the flow and structure of the blood vessels, whereas autofluorescence tells you about physiological and topographical information about the retina. So both are complementary and give overlapping information. So you need to use both many times together, but the least invasive, risky, or expensive, the better it is. Next slide, please. So we have our experience in the grading of autofluorescence images in serpiginous like choroiditis. I'll not go into the details, but this is how we stage them. Next slide, please. So if you see on the left, you have 1, 2, 3, 4. One is, these are all autofluorescence images, and one is when the lesion presents actively. Second, when you start treating, there is a stage 2. It starts becoming hypoautofluorescence or hypoautofluorescent, and this hypoautofluorescence increases in stage 3 and completely takes over the hyperautofluorescence. So in stage 4, which you see on extreme right, this is the ideal result that you need to have after treating your patients. Now let's see an example of this. The fundus photograph tells us that yes, there are some lesions of serpiginous like choroiditis, but clinically when you see, you're not sure whether these lesions are active or inactive, and what do you do? So as a conventional, when we were used to doing a fluorescein angiography almost a decade ago, more than a decade ago, we would straight away do a fluorescein and not really think of autofluorescence. So the fluoresceins in the early phases shows transmission defects and which are maintaining in the late phase. You really don't see much leak here unless you do an autofluorescence, which you see now here. Now, if you see this autofluorescence image, you see a lot of hyperlesions and a lot of hypolesions. That means a lot of lesions, a lot of parts of the lesions are there which are still active, and there is activity going on. So you need to treat these lesions. Now, once I start treating this patient based on autofluorescence, what I'm going to have is, next slide, I start with this and then move on to next. This is how the hyperautofluorescence decreases, goes on decreasing, and this is finally what you have. So I treat this patient based on the autofluorescence images. Coming to fluorescein angiography. So it has a very well-established role in clinical practice of uveitis, especially posterior and panuveitis, both in diagnosis as well as management. It differentiates active from inactive uveitis. It helps in diagnosing coexisting pathologies like cystoid macular edema, choroidal neovascularization, etc. It helps in identifying areas of capillary non-perfusion as well as retinal neovascularization, and helps in monitoring response to therapy. Now coming to the role of fluorescein angiography in retinal inflammations, you have a case like this where you can say, of course, there is vitritis in both the eyes, more on the left than the right. And beyond that, you really don't see much of any vascular phenomenon or anything like that, unless you do a fluorescein angiography, where you see there is so much of leakage from the vessels in both the eyes, and it's difficult to actually categorize this patient as vasculitis unless you do a fluorescein. And even it tells you not only about the active leakage all over, but also tells you the pattern of leakage. It is most likely a fern pattern of leakage, probably dealing with the case of Behçet's uveitis. Another case where you see some subtle activity occurring in the macula, this patient comes with decreased vision because of the obvious involvement of the macula. So probably some kind of retinitis going on, and you do a fluorescein angiography, and you see that not only this lesion is active, but also there is vascular leak. So you see, you have an element of vasculitis there. Now, this case is a very obvious case of vasculitis. You would do a fluorescein, but for different reasons, not for detecting vasculitis, but to characterize, to know the perfusion. And let's do the fluorescein and see what's happening here. So we have a lot of capillary non-perfusion areas, right? So this tells us that this is an ischemic type of vasculitis, and the information of this can be only obtained from fluorescein unless you have a vitreal bleed or a subhyaloid bleed. So it's very important to do a fluorescein angiography in every case of vasculitis. Now, when we talk about fluorescein fundus photography, we cannot ignore ultraviolet field imaging in posterior uveitis, and this is an example. Now, you see this case of bilateral exudative maculopathy. This patient comes with decreased vision on and off going on for 3 to 4 months, and all that you see is a lot of exudation all over in the macula, around the arcades. And if you notice carefully, look at the vascular pattern. You follow the vessels in the periphery and you see some kind of sheathing is there. So what do? You have sheathing, you don't have any bleed, you have these exudates. Now, when we do the OCT, we see there is some kind of subretinal fluid, some exudates which are clinically correlating. And unless we do an angiography, which gives a clear-cut diagnosis of idiopathic retinal vasculitis, aneurysms, and neuroretinitis. So you see these retinal aneurysms at arterial bifurcations. It's a clear-cut case of IRVAN. You would not diagnose this unless you do a fluorescein angiography. Next, please. Continuing with the role of ultraviolet field imaging, a lot of cases of posterior serpiginous like choroiditis have peripheral involvement, majority of them. So if you see this example, now this is an ultraviolet field fundus photography of a case of serpiginous like choroiditis. Now this white circle indicates that this is what you see from a conventional camera. So you would not see much what's going on here unless you see the periphery and unless you do the ultraviolet field angiography, which shows that you have these lesions, so many active lesions in the periphery. This was a young child who came with bilateral loss of vision, and we see some kind of frosted branch angiitis in both the eyes, more in the left and right. But again, you need to characterize. So when we do the fluorescein angiography in this case, we see that there is a lot of vascular leak, disc leak, and complete 360 degrees capillary non-perfusion in both the eyes in periphery. So this tells us that there's a lot of ischemic vasculitis going on, even in the absence of any hemorrhages in the retina or in the vitreous. So this Optos technology is designed to operate through a minimum pupil diameter of 2 millimeters. Unlike the convention, a lot of people think that Optos is meant only for dilated pupils. It's not so. If you have in uveitis, you deal a lot of times with small synecdoche, small pupils because of synecdoche. You're not able to see the fundus. So Optos helps you a lot. I would say don't go for conventional photography. Straight away take the patient for Optos if you have the facility. I'll give you an example of this young boy with bilateral panuveitis presenting with these kind of synecdoche. So when we did his imaging on the conventional camera, the conventional fundus camera, the only thing that we could capture was this kind of hazy fundus view and hazy fluorescein angiography, which just told us that yes, there's some kind of leak going on, but it's inconclusive. We don't know what's going on. So next, please. This is the late phase. Again, nothing conclusive unless we did the Optos. So we did perform the Optos angiography in this patient. And see, we see not only the complete view of the retina, but also we see these kind of vasculitis with choroiditis. And when we see the angiography, you have these kind of lesions all over. So you have choroiditis, vasculitis bilaterally. And now, next please. When we compare it with the conventional, we are clueless. So Optos gave us complete information, and this child turned out to be having Behçet's vasculitis with panuveitis, and we were clueless when we did just the conventional angiography. So ultraviolet field angiography is an essential or an add-on. It depends upon how it helps you in your clinical practice. So it gives you simultaneous evaluation of the peripheral and the central retina, avoids field overlap of a montage that you need to create with the conventional fundus cameras, and of course added advantage in small pupils like I showed you and in patients with mediocrities. Coming to the role of fluorescein angiography in choroidal inflammations. Now, this is just look at this case. Let's have this case as case number 1. And we now have case number 2. So when you see these two cases, they look quite similar in the sense that they have exudative detachments. Both are bilateral. And let's go on to the third case. Again, this kind of exudation in the right eye, which is more prominent posteriorly and of course with inferior exudative detachment. Now let's go to the next slide. Yeah. So this slide is the angiography of the first case, where you have dye pulling in the late phase, a very classical example of acute VKH. Now go on to the next case. Second case that I showed you looked very similar with bilateral exudative detachment, but this patient had decreased vision going on since childhood, more since 1 month. So this history is not very consistent with that of acute VKH. So you have to be on your guard. Every exudative RD is not VKH. Pay attention to his vision, 660, with best corrected with plus 14 diopters. So this is important. Decreased vision since childhood, going on and off, small eyes, plus 14 diopters, 660 vision. Next. When we do the OCT, we do see subretinal fluid. So any subretinal fluid, as I said before, is not VKH. And when we confirm on fluorescein angiography, so the right eye practically shows nothing much except some kind of pigmentary changes. Nothing similar to what we saw in case number 1. And as we move on, the left eye is almost normal, absolutely normal. So we don't see any features of dye leak or dye pooling. So we move on. We pay attention to the biometry and it shows that the axil length is very small in both the eyes. And then we look at this patient from a different perspective. So it was the fluorescein which told us that yes, it is not exudative detachment. We go for MRI Orbits, which confirms that both these scleras are thickened. And this was actually a case of uveal effusion syndrome. So a fluorescein rules out VKH and gives you clues like pigmentary changes and so on. The third case that I showed you, with so much of, again, exudative detachment and this fibrinous reaction in the right eye, left eye was practically normal. This patient was treated elsewhere before he came to us as a case of, first as a case of choroidal granuloma, received ATT, did not tolerate ATT, did not improve with ATT, stopped ATT. The physician thought it is VKH, gave high dose steroids. And when the patient comes to us, we just did the fluorescein angiography. So here we see that there were multifocal leaks. So this is a case of multifocal CSC with fibrinous detachment and not anything like VKH. So all that we did was taper the steroids and stopped. And the outcome was, this is how the patient responded. The entire fibrinous reaction resolved, just a little bit of scarring at 7 months. Coming to ICG angiography, the theoretical, you know quite a lot about it. It's just that it's a method of choice to analyze choroidal inflammatory pathologies. It shows occult choroidal lesions which are subclinical and may not be seen clinically or on fluorescein angiography. And hypofluorescent lesions, or I would say hypocyanous lesions, result from choriocapillaries non-perfusion or stromal inflammatory inflammations. And hyperfluorescence results from leakage from the large inflamed stromal choroidal vessels. So based on ICG, the choroidal inflammation can be classified as inflammation of the choriocapillaries, which is choriocapillaritis, or inflammation of the choroidal stroma, which is stromal choroiditis. So when we talk of choriocapillaritis, you have a list of differential diagnoses. On the left, when you have stromal choroiditis, you have all these VKH, sympathetic ophthalmia, and secondary stromal choroiditis like TB and sarcoid. So let's see an example of this. You have these multiple hypo lesions. The girl presents with decreased vision in the left eye. So when we did the combined fluorescein and ICG of this patient, now these lesions you can see are quite deep, subretinal. They're not causing any elevation of the retina. They're not causing any exudative detachment around them. They're much below the retinal blood vessels. Right eye looks practically normal unless we do the combined fluorescein angiography with ICG. So here we have, if you just look at the fluorescein, it shows that there's some hypolesions in the left eye which become hyper in the late phase, but nothing typical of serpiginous like choroiditis. And next, when we look at the ICG frames, so this is the combined FFA and ICG. If you look at the early frames of ICG, where I've put the red arrows, you see there are hyposinusal lesions even in the right eye. And you have many more lesions in the left eye on ICG as compared to the fluorescein angiography, where you see the red arrows. So these are the early frames. We go to the late frames. So late frames, again, you have many more lesions on the ICG as compared to the fluorescein. So ICG gives you added information in choroidal pathologies. This is a case of classical, the typical TB serpiginous like choroiditis. I would say you really don't need ICG nowadays because we are monitoring these patients with autofluorescence. But this is just to show that, again, this is a kind of stromal choroiditis or a choriocapillaris, which gets very beautifully demonstrated on ICG. So when we do the fluorescein and ICG of this patient, what we see is hyposinusant lesions in the early frames, which remain hyposinusant in the late phase. A case of disc edema referred to our center actually as a case of papilledema, but this patient was seen in the eye center, and we noticed these subtle granulomas in the left eye, if you see. And the only thought that came to us was, let's do an ICG, because these lesions are subtle, they're deep in the choroid, and disc edema is probably a secondary phenomenon which is occurring. And we were right. We did a combined fluorescein and ICG, which showed that if you see the early frames of the right on the top, there are a lot of hypo lesions in the ICG, which is on the right, and not much going on in fluorescein because these lesions are purely choroidal. And if you see the early frames of the left eye, the entire left eye is filled with granulomas, which are seen on ICG and nothing is seen on fluorescein. So we move on to the late frames. The late frame on fluorescein, which is on the left, shows only disc hyperfluorescence, that yes, clinically we saw disc hyperemia, and in the late phase, the entire choroidal stroma is filled with granulomas. Coming to OCT, yeah, we know its role in detection and monitoring of cystoid macular edema. This is the spectral domain, and this is following Ozurdex implant as an adjunct to fluorescein angiography. This is another case where you just use OCT to monitor the response to therapy. Now, the OCT, when we deal with OCT, it gives us very important information whether we are dealing with a choroidal lesion or a retinal lesion. And that's my favorite topic when I teach the postgraduates. Whenever I take these teaching lectures, especially for the postgraduates, the common question they ask is, what is the difference between a choroidal lesion and a retinal lesion? So there are few tips clinically and on OCT, and again then on fluorescein, and I'll give you an example by this. Now, the one on the left, and you have another patient on the right. Both these patients present with decreased vision, acute, maybe 1 week or 2 to 3 weeks duration. Yeah, it's almost 1 week. The one on the left has a markedly reduced vision to the level of counting fingers. The one on the right is 612. Both these lesions are in the posterior pole. So why is it that one lesion is causing so much of decreased vision and the other lesion is not? Now let's see the configuration of these lesions. The one on the left is a deep lesion surrounded by exudative retinal detachment. The one on the right is a fuzzy lesion. It's not very well demarcated. It's superficial. It's feathery in appearance, and it doesn't have any exudative detachment around it. Now, what next do we do? So we do the least invasive, and we immediately take up these patients for an OCT. OCT gives you almost a 90%, 95% of the diagnosis. The one on the left, the OCT scan shows subretinal fluid, subretinal fibrin, and more important, there is a bumping of the RPE retina complex. So there's something in the choroid which is pushing this entire complex. It's not a straight line. So all that pathology is primarily in the choroid, and all the subretinal exudation and fluid is secondary to that. So that means it's a choroidal granuloma. And the one on the right shows a straight RPE choroid complex, and whatever is happening in the retinal layers. So this is nothing but a retinitis, and the one on the left is a choroidal granuloma. Now let's see how we see these lesions on fluorescein. The first case is shown on the top and the second case on the bottom. Now if you see the fluorescein, choroidal lesion always has initial hypofluorescence. Late phases, the hypofluorescence increases dramatically, and if you have exudation around it, you have dipooling. On the other hand, a retinitis starts with an early hyperfluorescence because of involvement of the retinal vessels around it, and it becomes increasingly hyperfluorescent in the late phase. So this is one important differentiating feature of a choroidal lesion and a retinal lesion. They respond also differently. Now, what did we do to the first one? Yes, first one was a case of TB choroidal granuloma. We treated with anti-TB therapy, and the outcome is very different. As we see now, these choroidal lesions heal with significant scarring. And the retinal lesions, if treated in time, do not leave much of scarring as seen here. Next, please. So this is another case of retinitis. So I'm just demonstrating the use of OCT. Next, please. So we did an OCT scan through this. It's not always compulsory to do a fluorescein angiography in these cases. When clinically you are very sound with the diagnosis of toxo, your history tells us maybe you have a serological titer with you. So all that you do is clinically you know that it's retinitis lesion quite fitting into toxoplasmosis. You do an OCT, you see that the retina is involved, and it may be a retinochoroiditis where the choroid is involved secondarily. And we treat this patient with the antitoxotherapy. The lesion starts decreasing in size, and we monitor these patients on fundus photography and OCT. We don't do anything much in these patients on follow-up. Every visit, we do an OCT and a fundus photography. So this is how we monitor. The lesion starts decreasing. Go to next. So this is with the further treatment. These kind of granulomas, when you see orangish granulomas, multiple, mostly in the posterior pole, they're different from what I showed you earlier from the TB granuloma. Here, the lesions are orangish in appearance. They don't have that yellowish appearance. They don't have exudative attachment around them. They're multiple in contrast to the previous lesion, which was solitary. So these lesions are different from TB granulomas, and most likely these are the lesions of sarcoidosis. And we do OCT in them, and we see these granulomas in the OCT. You can see these hyporeflective spaces in the choroid. These are nothing but granulomas. This kind of fuzzy lesions, a case of intraocular lymphoma where you have subretinal lesions. Subretinal, I would rather say sub-RPE and not subretinal, because when you do the OCT in these patients, you see that these deposits are beneath the RPE and above the Brooks membrane. So subretinal means between the neurosensory retina and RPE, but sub-RPE means between the RPE and the Brooks membrane. So these lesions are classically sub-RPE, and when you treat them, the lesions disappear clinically as well as on OCT, and the entire complex becomes flat, as you see here. Next, please. Continuing with the OCT we have the EDI OCT, which is enhanced depth imaging OCT. For obvious reasons, it tells you about the information about the choroid. I'll give you an example of the importance of this EDI OCT. This patient, a female, presenting to us with complaint of heaviness in the left eye. Now, clinically, when you see her vision is 6/6, she's a known case of leakage, having been tapered steroids, and she's on immunosuppression. And she just comes for a regular visit. I mean, she took the treatment somewhere else and she comes for a regular visit to us. And you see that her vision is 6/6. She just says, I'm having heaviness in the left eye. Clinically, there was nothing. Fundus was normal. We did the fluorescein, we just found that there was some leak in the disc. That means there is some inflammation component in the eye, but where? Because fluorescein did not give us any granulomas or any subretinal fluid. So when we did the EDI OCT of this patient, the top scan is of the right eye, which is normal, and you look at the bottom scan, which is of the left eye. If you compare the two, these blue arrows mark the boundary of the choroid, where the sclera starts. So look at the difference. The choroid in the left eye is thickened so much as compared to the right eye. So that means there is choroidal thickening and there is subclinical with inflammation going on in the left eye. And that was the reason for her heaviness in the left eye. We did the ICG angiography just to confirm because we had got our answer by EDI OCT. When we did the ICG angiography, we saw some hyposinusal lesions in the late phase. So early phase did not show us anything, but late phase showed us some granulomas. So it was this disease was picked up at a very, very early stage before the patient developed full-blown recurrence. A case of serpiginous-like choroiditis captured on ultra-wide field photography. So I will just demonstrate you the role of EDI OCT. So this is what we did. We did a combined of autofluorescence and EDI OCT in these patients of serpiginous-like choroiditis. So it is the choroid also which is diffusely inflamed. And as we keep on treating the patient with steroids and ETT, the choroidal thickening reduces, and beneath the lesions of the choroiditis, the choroid shows atrophy. So the EDI OCT in serpiginous-like choroiditis also shows that there is choroidal thickening. Coming to the hot topic, OCT angiography. Now you have this patient of a healed serpiginous-like choroiditis coming to us with sudden onset decreased vision in the left eye. Now clinically, if you're an expert, you would pick up a hemorrhage, but sometimes in the background of this scarring, we may not pay attention to it, and we think probably the patient has bad vision right from a few years because of this scarring. We may not pay attention. So we just do, because we listen to the patient, we do a fluorescein angiography. And it shows the window defects. And some kind of, if you see the bottom frame, some kind of leak near the fovea. Now, do you really infer from here that this leak is from a CNVM? Because in the early stages, we don't see much. So what is the way of confirming? We confirm by OCT angiography. So before that we do the OCT, which shows some kind of complex in the subretinal space with fluid, and we need to confirm, which we do on OCT angiography. So here. So the inverse shows a huge choroidal neovascularization, the entire network that you see, which normally you don't see. So this confirms that there is an inflammatory CNVM, which is causing decreased vision in the left eye. Another case of bilateral serpiginous-like choroiditis, which has healed significantly, and patient presents with decreased vision. We do a fluorescein. Next, please. Now, this fluorescein is so confusing. You have scarring all over, and you have some kind of leak in left eye. we don't know because there's so much of heavy scar fibrosis here in the fovea. So the staining is probably of the scar tissue. So we are quite clueless here in the left eye, and right eye we see some kind of staining again. Now, how do you know with this staining is of the scar or is it from a membrane? So we do an OCT angiography. Before that, of course, spectral domain OCT is a rule. So again, we don't have much information here. We see the RPE changes, we see the outer retina changes, all because of all secondary to the serpiginous choroiditis scars. So till now, with all these investigations, we don't have much clue unless we do an OCT angiography, where on the NFAS you can see a very well-defined choroidal neovascular complex. So again, this was a case of an inflammatory CNVM, which is difficult to detect in the background of scarring. So it's better to do an OCT angiography. Another case, now here we have, this was a case of optic disc neovascularization in serpiginous like choroiditis. So what I'm trying to show here is that you do see neovascularization on the disc in this case, but how beautifully we capture this NVD on OCT angiography, which is the extreme right frame. And more than that, this is when we gave anti-VEGF to this patient, this is the pre-anti-VEGF, and what happened after anti-VEGF, that also you can document very nicely with OCT angiography, scan centered on the disc. So this is what we have after the anti-VEGF treatment. So you see a complete regression of the neovascularization over the disc, and which is beautifully captured on the OCT angiography. So when you talk individually about these imaging, of course, you need to resort to multimodal imaging. So we have this patient presenting with decreased vision in the left eye since 1 month, and this decreased vision was sudden in onset. Vision had gone down to 636. Now, clinically, you see some kind of hypolesion or little smaller than the disc, a white kind of coin-shaped lesion involving the fovea. Now, the first thing that comes to your mind as a clinician is whether it's inflammatory or non-inflammatory. So how do you proceed? So you do the least invasive test before you go for anything, which is spectral domain OCT. And you see multiple scans. This is one scan, and the below one is a scan below. So you see a breach in the RPE. You see a hyperreflective subretinal complex. Probably this is some fibrin or a CSR because you see some breach in RPE. And so we do the next test. A fundus autofluorescence, and here we have the typical gravitational pattern of the trickling fluid going on for some time, very nicely captured on fundus autofluorescence of the left eye. And when we confirm on Fluorescein angiography, so you have this expanding dot sign in the late phase. So this confirms your diagnosis. So this is the role of multimodal imaging, where you have this kind of fovea threatening lesion. You do an autofluorescence, you do an OCT, you get your clues, and you are almost sure, and you just confirm by doing a Fluorescein angiography that this is nothing but a case of a fibrinous CSR. And many times it is mistaken as some kind of uveitis, maybe a choroiditis or a retinitis. So we just observe this patient, and this is how the patient presented with the top scan. The bottom scan shows the resolution of all this pathology at 6 weeks follow-up, and the vision improving to 6/9. Ultrasound biomicroscopy, I think the first thought that comes to us is, why in posterior uveitis? I'll tell you, more than posterior uveitis, it's more important in pan-uveitis, where you have so much inflammation targeting the ciliary body. So what is the use of this? So it is not strictly limited to interior uveitis or chronic interior uveitis, but many cases of pan-uveitis, we do resort to UBM. And this helps you to assess the inflammatory lesions of the iris, ciliary body, pars plana, and peripheral vitreous. These structures are not readily accessible with routine examination methods. We know that. So the two groups of patients for which UBM is very important are those with opaque media, because you may have a very dense or horrifying panuveitis going on, and those with hypotony, again in eyes with chronic inflammation. Pseudophakic uveitis, it's helpful to assess the location of the haptics in relation to the iris and ciliary body. So this is how normally the ciliary body and the ciliary processes look like. You can see these arrows on the left, which shows the ciliary body, and the scan on the right shows beautiful finger-like projections of ciliary processes. So you have the arrow showing the supraciliary and the suprachoroidal effusion and a ciliary body cyst on the left. Or you can have a very well-defined cyclitic membrane where you have blunting of the ciliary processes, or maybe complete absence of ciliary projections. Ciliary body mass, again, you picked up by UBM. And in eyes with pseudophakic uveitis, you need to sometimes do a UBM where it shows the haptic of the intraocular lens touching the ciliary body in a patient with pseudophakic uveitis. The hyperdense haptic that you're seeing on the right in the ciliary body can clearly be identified resting on the ciliary body. So it is the haptic of the IOL which is resting on the ciliary body and causing chronic inflammation in a pseudophakic eye. B-scan ultrasound is, of course, the use is in opaque media, or where the visualization of the fundus is poor because of hazy media, whether it's cataract or it's vitreous hemorrhage or it's very significant dense vitritis. So we resort to B-scan ultrasound. And chronic VKH, we used to use it long time back for thickened retinochoroid, but nowadays it doesn't really it's not required, because we have now the EDI OCT, and I showed you how beautifully you can capture the thickened choroid on EDI OCT in the cases of VKH. So of course, one condition where completely visible fundus, you need the ultrasound, is in posterior scleritis, where you can demonstrate the T sign and confirm your diagnosis. Or for differential diagnosis of various masquerades like intraocular tumors. So to summarize, imaging in posterior uveitis is extremely important for establishing your clinical diagnosis, and you need to be careful about the choice of investigation because it depends upon the site of inflammation and the type of inflammation and the phenotype that you're seeing, whether you're dealing with a choroidal inflammation or you're dealing with a retinal inflammation. So many times we do need to perform multimodal imaging to get completely useful information. Thank you very much. And once again, I thank all of you. My sincere thanks and apologies for being with us for so long, waiting for this lecture, and being so patient. Thank you so much.
Thank you so much, ma'am. We'll wait a couple of minutes. If anybody has a question, you can write on the chat box, or you can unmute yourself and ask directly.
I think it's better to ask rather than typing.
So at this point of time, we don't have any question, ma'am.
Okay, then.
So I think, okay, I'm sorry. Ma'am, how to remember all the findings of FFA, ICGA, autofluorescence findings in uveitis? How to remember?
No, you don't have to remember anything. All imaging is something, it comes with experience, and the more you see patients, the more you do imaging, the more your experience is, the more you learn. There is least theoretical about imaging, and it's more of practical and practical. So as you become experts, you'll be experts in imaging. Don't worry.
Active versus healed lesion by ophthalmoscopy.
See, if we could do that, I don't think we would need imaging. So, yes, clinically, when the lesion is fulminant, acute, the patient presents with, when the patient is symptomatic and the patient comes to you. So you can pick up, you can correlate, yes, there is an active lesion. But what happens is, you are sitting in a place which is far off. The patient comes to you through one center, second center, third center. Probably the patient doesn't even visit anybody. So when you see the patient in late stage and you see it's been going on for months, the clinical presentation has changed. Probably that is the time when the lesion is healed. So if I'm talking about a choroidal lesion, if you have a raised lesion, yellowish looking, margins are raised, vessels are raised, there is some amount of hemorrhage or exudative detachment, you're dealing with an active lesion. If you see some kind of pigmentation is there, probably the lesion has started healing.
I think we have one question from Dr. Abhilasha. He is trying to speak. Dr. Abhilasha, if you can. You need to unmute your mic.
Or maybe you can type.
आपको कैसे पता लगा मनीष जी कि डॉक्टर अभिलाषा क्वेश्चन पूछ रही हैं?
So that circle was on round. If some sound is coming, no? So
Okay,
that
it
itself.
gets highlighted.
In the meanwhile, ma'am, can you again tell about autofluorescence and ICGA finding in serpiginous choroiditis? ICGA finding.
ICG would be hypo to hypo. The lesions will be hypo in the early phase and remain hypo in the late phase. Autofluorescence, you have hyper autofluorescence to begin with. And when the lesions start healing, the hyper autofluorescence starts getting replaced by hypo autofluorescence. And it starts becoming hypo, goes on increasing hypo and becomes completely dark.
From where do the pigments come over healed lesions?
All this is in proximity to the RPE. So the more the lesion is in proximity to the RPE and choriocapillaris, the more pigmentation you have. So for example, I give you an example of retinitis. If you have a retinitis which is primarily a retinitis and not really involving a choroid, and you treat early, the RPE is spared, the choroid is spared, and you would not have pigmentation. So it all comes from the pigments which are present in the RPE layer.
Okay. Thank you, ma'am. Those were the questions for today. Once again, I'd like to take this opportunity to profusely and deeply thank you for the time that you took out. We are very, very grateful to you. On behalf of all the postgraduates, I would like to thank you very much for your presentation. I would like to inform all the postgraduates that tomorrow we have Dr. Anirudh Agarwal with us, who will be speaking on viral anterior uveitis, and that will be at 5 o'clock. If you have any questions, you can write to me regarding imaging in posterior uveitis, and I can forward it to ma'am and she can reply to you. Otherwise, for today, we will finish this session here. Thank you so much for your patience and cooperation, for the extra time that it took. Thank you so much, and we'll see you tomorrow evening again. Thank you so much. Thank you, ma'am.
Thank you.
Thank you,
Thank you, Dr. Sinha. Thank you so much.